All right.
Go for it, Joe.
Thanks,
Next.
Jim. So I'm going to talk about cognitive behavioral therapy for chronic pain from a perspective of a primary care person, because I'm not a therapist or a psychologist. So this is basically trying to get cognitive behavioral principles in our chronic pain management skills. So I'm going to talk today about some non-pharmacologic pain management options, briefly, some cognitive behavioral therapy issues in chronic pain, and sort of what I do as a primary care doc, kind of CBT light. And then basically these are strategies really to change the conversation in chronic pain patients away from medications and other passive therapies to giving patients more active therapies that empower them to help themselves. So next slide. So most of our medical training emphasizes the medications, the opioid and non-opioid medication management issues in chronic pain, but there are lots of non-pharmacologic modalities that have evidence. They may or may not be available to any given patient, may not be affordable, but I think that it's our obligation to help the patient balance some of these the medication issues with non-pharmacologic methods. So I'm going to distinguish passive from active approaches, and that I think is the key distinction. Medications and medical procedures are passive, and they really are only partially effective for chronic pain. Next slide. So the passive things do include medications, but they also can include a lot of alternative therapies, acupuncture, massage, chiropractic, TENS, myofascial release. A lot of these things are not necessarily in our armamentarium as physicians or in the allopathic traditions, but often they're available to patients. But I think however many our patients seek, it's really important to balance them with more active things. We talk about that a lot with exercise and physical therapy, but also coping, sleep hygiene, biofeedback. There's a lot of behavioral issues that go that patients can take on and improve their chronic pain. Next slide. So treatment for chronic pain requires non-medication approaches as well as medication approaches. And many patients really have never gotten any kind of evidence-based non-medication treatments, and the CBT strategies have been shown to be effective in treating chronic pain when they're applied in a formal setting like a clinical trial. Medical providers, though, can develop some knowledge of CBT, and that's my goal today, and facilitate appropriate treatment either outside the medical setting, or I think it's really important to check in about the strategies patients are using so they know that it's important from the medical perspective as well. So, and a lot of these things can be integrated into primary care, even if it's in more of an education mode. Next slide. So a standard CBT would be, 12 sessions once a week, an hour with a psychologist or a therapist. You can tell if it's CBT if it has homework, because there's homework review, new strategies, goal setting, and new homework are common sort of format for CBT, whether it's for chronic pain or for a lot of other disorders that CBT has been shown effective. CBT Light, though, is more like what I would do, and really brief discussions and providing written resources. And I use this Managing Chronic Pain, a cognitive behavioral therapy approach by John Otis, to do that in my practice. Next slide. So I can't say that this is all evidence-based, but I think it's practical, and it really helps in terms of giving strategies for patients. It also, I think it really changes the conversation and the encounter towards discussion more about what patients can do for themselves, and really it complements medication strategies. You can also get a sense of how the patient's thinking about their pain and some dysfunctional beliefs that they may have about their pain, and sort of why and what they see medication as being potentially able to do. Next slide. So when I'm introducing this to patients, I'll bring out my little book that's got each chapter copied, and I can give it to them one at a time or a few at a time, and I'll show them this is a strategy that I use with a lot of my patients, and I'll say the idea here is that pain is really often made worse by a lot of different things like poor sleep or too much activity or too little activity. And by the time I finish this sentence, most patients are nodding. They understand if they don't get good sleep or if they do too much, their pain is worse. And then I also say on the other side, pain often does lead to problems like muscle tightness or shallow breathing or negative thinking about your life and future. And that also, I think, patients really acknowledge. So the idea is to get their buy-in for this program that gives a lot of different strategies. It's really a menu of things that you can do to help manage your own pain. And it's likely you've figured some of this out on your own, but I like everybody to have an opportunity to get the range of options. Next slide. So the first 3 chapters is what I'll give patients. There's an overview of the program, some education about chronic pain and the cycles of pain, distress, and disability, and just sort of more of a summary about what makes pain better and worse. And then there is a chapter on theories of pain along with the breathing exercise. And really the goal of this theories of pain part is to distinguish pain from tissue damage. I'll say something like there are patients with a lot of tissue damage who've had bad trauma who don't end up having chronic pain. And then there are some patients who have no tissue damage that we can see, but a lot of pain, and that might be a fibromyalgia patient. And I think patients understand this or can understand it, but it often takes a few tries to get the implications of it through. But I think it also acknowledges that you don't need to have tissue damage to have a lot of pain, and that you're going to believe their pain. You're going to think their pain is a real thing, even if I can't see it on an X-ray. And then the diaphragmatic breathing section of this chapter is really about helping them come up with that pain can restrict breathing, and this tool can help respond to that. I don't think there's any CBT program that treats anything that doesn't have some mention of a breathing exercise. Next slide. So I've given them those chapters, and of course I'll document in my note what I did, that I gave them those chapters, and then I'll pay special attention to bringing it up the next visit, simply because I think it's pretty common for docs to say this is the education you need and then never think about it or talk about it again. And I really want them to understand that I think it's important, so I have to bring it up again. Sometimes they'll have lost it or hadn't read it or left it in the waiting room or whatever it is. And if not, I just offer them again. And really, it's a form of resistance that when they don't do anything, and I'm really putting it back on them. It's up to you how much of this you learn and apply. And then if they did do something about it, I just try and get their sense of what was helpful, what wasn't helpful, and if they did any of the goal setting or any of the breathing exercise. And some people do take this on and really feel like it adds to their daily life, something they can do to respond to their chronic pain. And then I'll offer some more. Next slide. The second 3 chapters I also give just all at once because there's more information there, but there are some more also tools like muscle relaxation, visual imagery. Some patients really find helpful. And then there's 2 chapters on really negative thinking, automatic thoughts and pain, and cognitive restructuring. And I just sort of group that as negative thinking that can make pain worse. And there's some tools there that they can use. Now, in real CBT, this would be a big focus, and there'd be a lot of discussion and trying to actually specify which thoughts are triggering which emotions and which emotions triggering which behaviors and how that all fits together and where they can intervene. I don't take it to that level, but a lot of patients have figured out that their sort of negative or positive thinking is important, and they may be interested in learning more. Next slide. And then after that, I don't do it after I give them that sort of basis and the overall idea, then I'll be more focused in depending on what the patient feels might be helpful, whether it's about sleep or the activity. Time-based pacing is a great chapter. And those two I'll talk about a little more. But then there's stress management, anger management, pleasant activity scheduling. Those are ones that, I mean, the stress management chapter is so broad. I never thought anybody would really get that much out of it, but people do. People come back and say, yeah, I really found it helpful. So I've given up sort of guessing what patients might find most helpful and just offer whatever they want. Next slide. The time-based pacing chapter, though, is one that I will always include at some point. I think just identifying that patients commonly have the pattern of having to get stuff done, and even though they're having a lot of pain, and getting up and pushing through that pain, and by the end of the day they're really done, and maybe even in bed for a couple of days. And that's a pretty common pattern, so I get a lot of head nodding when I describe that. And having too much exercise is really not so good, but it's also true that too little exercise, if you end up in bed for a couple of days, you're never going to get stronger. So everybody, and the goal here is to really help the patient define what level of activity is appropriate. And the way I do that is to ask them to find an activity that they can do every day. So if they can't, so whatever that activity is, if they are done with it and the next day they can't do it, they've done too much, even if it's a very little bit. And the idea is to, if they have housework, that they might pace themselves before they get in a lot of pain, stop and rest, and then go back to it. So you have small incremental activity during the day instead of big activity followed by no activity. And you can find that activity and use that like the pain tracker does to as a functional metric, what their activity level is. Next slide. And then sleep hygiene is really important and very common in chronic pain patients to have problems with that. So these tools have been shown to be more effective than pills, and that is true. There's actually whole courses, CBT courses in sleep hygiene. I give them a chapter that's maybe 3 or 4 pages, and it has a checklist. It also has the kinds of sleep hygiene advice that you might give, but it's a little bit more complete probably than what you would get through. And also it gives them something to take with them so they don't have to remember all the things. And then you can check in about how it went at the next visit. Again, it's up to you how much you do of this, but a lot of patients have found it helpful. Next slide. So managing pain flare-ups. This is, I think, there is a chapter about this in the book, and I do give that. But I think mostly it's a way, if you've already gone through some of these CBT topics, then when a patient presents with a flare, my pain is worse, there's such a big urge to reach for the prescription pad or do something about their pain flare. Whereas if you've gone over the things that make pain better and worse, then maybe you could ask a question like, what's been going on in your life? And really, I found that's so commonly associated with pain flares. Their job is having stress. They've had to move. They lost the book that you gave them or the chapters. They stopped doing the exercise because of those stresses. So getting to the bottom of it really allows for a whole set of responses that are more about what the patient can do. So have you tried any of the tools? And many patients will have stopped them after finding some success because maintaining behavior change is hard for all of us. So getting back on the wagon in terms of those tools and finding ways to use the skills they've developed in the past to manage pain flares really takes the conversation away from what are you going to do about my pain flare, doc? Next slide. So what I've learned from doing this, I'm actually pretty surprised that after doing it for a few years, I still bring out that book pretty frequently and talk to patients about these issues. I'm also surprised at the kind of response that I've gotten. Many of them many people, especially if they've had some addiction history and have been in recovery, a lot of the principles are similar to what they've heard in their recovery programs. I also can't predict which of the chapters are going to be good for a particular patient. And I do find that if you're going to go into this, it is helpful to have a little bit more frequent visits than is typical in primary care. So maybe fitting in a visit, if you see somebody every 3 months, maybe fitting in a visit or two in between those just to go over this. So you may be able to spend more time on the CBT part if you see them back sooner, because there isn't as much to do primary care wise. And it's really has been gratifying to watch patients take control of this and learn from it. And I think it's really helped me to understand also why patients, what their barriers are to doing behavioral change to help their chronic pain. Next slide. So this is the book, Managing Chronic Pain, a CBT Approach. There's other ones. You can find this. It's about $25. You can get it through Amazon. There is a therapist manual and there's a patient workbook. I just stick with the patient workbook. And I think just reading that gives you a lot of ideas for talking to your patients. And then there's lots of other CBT resources in that same series targeting a lot of mental health issues. Next slide. And then there's a book by a UW professor, Dennis Turk, Pain Survival Guide. This is more of a chapter book and really follows the same approach. And then I think we've looked at the Understanding Pain, What to Do About It in Less Than 5 Minutes video. If you haven't seen it, I really recommend it. It is a really great summary of the CBT approach to chronic pain. And I've really gotten some mileage when I've sort of felt like I'm getting a lot of resistance from patients, or they're not taking this on with the same sense of urgency that I have for them. I'll maybe watch the video with them and see what their reactions are. And I think it can really open up the conversation, and it certainly impresses the patient in terms of what you think is important. And that goes a long way. Next slide. So this is just a summary. Including non-pharmacologic approaches to chronic pain is really important, and our support of that as medical providers is crucial for patients to get the idea that this is really important. Also, understanding these principles, it can help you guide the patients if they want to do this more, or find somebody who they can do a full CBT kind of program with. And incorporating the materials into the primary care setting. I found it really gratifying and interesting to work with patients on these topics.